Thank you, Chair. I'd like to ask the whole panel, but I'm conscious of time. So, Victor, if I may start with you, just continuing on the COVID discussion. Obviously, last year there were really worrying numbers shared around the percentage of the BAME population, especially staff, who sadly died through COVID. I wondered whether there's been any studies yet into the long COVID impact across the whole of the NHS and social care staff, but also looking in particular at the BAME population. Has that been done yet, or is that underway?
Well, thank you for that question, Dean. Firstly, the first 10 people to die in the NHS were black, and that rate of disproportion has continued. So it's terrifying for frontline black staff. As far as I'm aware, there hasn't been a study of the impact on long COVID in minority ethnic groups. One of the things that the Observatory on Race and Health is doing at the moment, in partnership with the College of Hygiene and Tropical Medicine, is looking at both the impact of COVID and the issue of the vaccine and how we relate that to BME communities and what leaders need to do to reverse that needle. But it's a very good point. We need to look at the impact across the piece. And as I'm aware, there are very few studies actually that people on long COVID that we've just started to look at as a piece, the impact of long COVID, but we should look at it on the disproportionate impact on BME communities, because it is having a disproportionate impact.
Absolutely, and I think one of the challenges there as well is on workforce numbers, and if long COVID does become something that's a large factor moving forward for all of the NHS and social care, but in particular in the instance of this select committee on the BAME population, my worry is what does that mean in terms of absence issues for individuals, long-term health concerns and so on. And looking at that from your perspective, if that sort of work starts to begin in terms of looking at that, how would you see that rolling out? Is there mechanisms at the moment to be able to measure that, to be able to get the feedback, to be able to get that sort of statistic, or do new mechanisms need to be set up?
My view is that new mechanisms do need to be set up to look at this. We can build on the mechanisms, the staff surveys, looking at talking to the clinical frontline, which I think is vitally important. It should be remembered that we went into this crisis with reported staff shortages across the NHS, and we were already challenged. This has not made it any better. And staff, all black and white, are working under tremendous pressure, as you know. I think what we need to do is deal with the challenges they face on the front line first and start removing some of those challenges. And for black staff, it is the continued sense that they are in the front line. They are literally facing the COVID virus, and the anecdotal evidence, which is evidence in of itself, in the absence of qualitative data, of quantitative data, you've only got qualitative data, and there's a lot of it, is that black staff continue to feel pushed into the front line, unable to get the protection and support that's necessary, and still being affected in disproportionate numbers. So the way to reverse that is to start listening more carefully to those staff about, well, okay, what are the supportive structures? How much control can we give you over your day-to-day work environment and the way in which you design and manage your work? Actually, the same principle applies to white staff, which is why I say it's about leaders leading older people all the time. So what we know from research about dealing with stress is that the more control you give people, the less stress they feel, and the more support you give them to remove the barriers, bureaucracy, etc., the more likely it is that they will feel in control. So those are the things that we need to do, but we need to particularly do that in relation to BM staff, because those are the people absolutely facing this on the front line in the poorest communities that we already know disproportionately affected.
And if I may, on that, I agree wholeheartedly on the red tape piece. It was a question from the early session as well around the impacts of that, which was, I won't explore further now because we covered it earlier. But the question I also have is about we talk about frontline workers, which I think for many people think doctors and nurses, but for me, if you're working in a hospital, if you're a porter, if you're a cleaner, you're just as in the thick of it as everyone else. In my local hospital, we have a large Filipino community as well, and I just wondered whether, when we're looking at when we're talking about frontline workers and when we're talking about BAME, are we reaching out to all members of staff across the board, from porters through to clinicians, and also all ethnicities, which may include the need for support with languages as well?
Just to be absolutely clear, when I refer to black and minority ethnic workers, I do include Filipino workers. And when I speak to talk about frontline workers, and certainly at the Confed, we don't just talk about the 44% of GPs that are from minority ethnic group, or indeed GPs. We refer to nurses, cleaners, porters, all of whom are disproportionately represented in the BME community. So I think your point is well made. I think we should commission the research on long COVID now. Let's not muck about. We're doing it. And on the, I think the question of understanding the conditions in which those people work and the communities that they come from is critically important, because there is evidence that those are the people that are least likely to be able to cope with being shielded, having to stay at home because they're on low wages. They're more likely to live in overcrowded conditions, so there's a greater risk of spread, and they have least flexibility over their job roles, which isn't to say they don't know. When I talk to porters and frontline workers and nurses, actually the amount of knowledge they have about how things could be done better is remarkable. It really is, but they're not listened to. Where there are good examples, and there are many good examples where they are listened to, you see the improvements immediately across the piece. So if you look at the Social Partnership Forum work that's been done by NHS employers, where frontline workers are empowered to share their experience in such a way that it leads to change. You look at North Bristol Trust's red card racism approach. If you look at Rob Webster's strategic approach in the West Yorkshire partnership around ICSs, you're starting to see the seeds of a shift in leadership and leaders taking responsibility for the culture they create. And the only test for a progressive culture and for a culture that works isn't at the top. They're the people that usually feel rock and roll. It's the people at the bottom. That's the key test. Do the people at the bottom feel that they are empowered to do the best and be experts in the work that they do? And I'm afraid we've got a way to go there. But the Confed is working with our members across Trust, Primary Care and ICSs to move the needle in that direction. That's what our reset report was all about.
Thank you very much.